thank you. My talk will be... Okay. My talk will be in 3 parts. First, I want to share with you the surgical approach in our clinic with regard to the ISOPURE lens. Second, I would like to talk with you about how we positioned ISOPURE in the clinic. And third, I would like to share some of the first data from a 100-eye retrospective study with ISOPURE. So as with most cataract patients in our clinic, we do bilateral surgery, not only for the convenience of the patient and family members, but also certainly within the context of high-tech lenses in order for the brain management to kick in much faster. We consequently apply mini-monovision, and we include up to 1.5 diopters of astigmatism. We reduce astigmatism then with opposite clear cornea incisions. And as it is the case for all lenses in the clinic, we don't use preloaded systems. We always rely on our AccuJect. Now, we talked a lot in the beginning about how to position ISOPURE. First idea would have been to position ISOPURE really as a new standard lens, so basically to replace our monofocal segment, to replace MicroPure. Then, of course, we would have ended up with a very high share of ISOPURE in the clinic and could have built only very small out-of-pocket costs to the patient. At the other end of the spectrum, there was the option to position ISOPURE as another high-end premium lens alongside with fine vision, of course, aiming at maybe only 10% of share of the IOL portfolio in the clinic. And then, of course, there's the in-between strategy, positioning ISOPURE as a modest premium. And basically, very soon we decided to go that way, aiming at around 30% IOL share. We achieved that share, and we even exceeded that 30% by how much I will show you on the next slide. We introduced ISOPURE in March 2020, and at that time we had in the clinic around 90% monofocals, the other 10% being trifocal and monofocal toric, a bit in a typical situation for as it is in any other clinic. And then after 8 months only, we achieved 30% share for ISOPURE. But then after, it continued growing and growing, and now today we have more than 50% ISOPURE, and at the expense of monofocals. Monofocals are around 40%, and the fine vision, the trifocal and the monofocal toric segment are more or less stable. So 800, I have implanted 800 ISOPURE within 18 months after introduction. That's a lot. A couple of factors contributed to that. First of all, of course, we have a lot of experience with the same platform. I have implanted more than 6,000 MicroPure lenses. As you know, MicroPure and ISOPURE are twins. Anatomically, they are completely the same, and yeah, it's MicroPure is a lens with very good visual acuity, precision. It's also very stable. I always say that you get actually a lens and a capsular tension ring for the price of one. And implantation is very reliable and smooth, and this is, I think, very important. Second, within the clinic, within the medical team, we very early on, we agreed on a positioning. We exchanged our early experiences, etc., at many occasions. And what helped a lot as well was that we tried all other Edov lenses as well. So with all other Edov lenses, I had like a series of 10 to 20 implantations, and we benchmarked all these newer Edov lenses on a series of parameters. One of them, as you see here, the ease of implantation. The ease of implantation differs quite a lot between the lenses, and ease of implantation, it is an important factor and an important parameter as well. And last but not least, from the beginning, we decided early on to conduct an observational study, and so we accumulated more and more insights on the characteristics of the lens, and we grew our level of confidence. And I'm excited to show you the first data of this retrospective study. I would like to thank Dr. Tomagova and Dr. Elai for their contribution. So it's a retrospective trial, 100 cataract eyes. We excluded vision-relevant comorbidities, and we have followed up the patients for around 6 weeks. In terms of surgery, we applied the same as I have shown you before, as we do for non-study patients. Bilateral surgery, minimum vision, and we included up to 1.5 diopters of astigmatism, and we then corrected it with also CI. So I can tell you up front, the results are very good. Maybe expected, the distance vision is uncompromised, but we have, of course, an extended range of uncorrected vision, especially the intermediate vision was very good, but also the near vision was not bad at all, and it did not come at the expense of quality of vision. I'm happy to go into more detail. This is the Edov curve, the binocular Edov curve for 100 eyes. As you can see, we have 2.4 diopters of functional elongation. So this means that from a defocus of minus 1.6 diopters to a defocus of plus 0.8 diopters, we stayed within the range of functional vision being defined as visual acuities of 0.2 logmar and more. So, of course, in theory, this covers well distance vision, but also the full intermediate range up to a distance of 63 centimeters. So now, how does that translate into visual acuities? First of all, and I think foremost, this is the most important parameter, especially with high-tech lenses like this one, the monocular corrected vision, and this was very good. Also, the binocular uncorrected distance vision was very good. So with confidence we can say that distance vision was good and completely uncompromised. Of course, it's all about intermediate vision here, and intermediate vision was excellent. And also the near vision was not bad at all for an Edov lens. So a nice extended range of vision. Now, when we asked the patients about spectacle independence, we used the PRISC questionnaire, and unsurprisingly, maybe the more than 90% of patients reported that they were very comfortable at distance, but also at intermediate. And we even had 40% of patients reporting that they were very comfortable at near vision without any correction. Now, again, does that come at the expense of quality of vision? We have confronted all the patients with pictures of the three photopic phenomena, glare, halo, and starburst. And actually, only 1 month after surgery, there were very few patients reporting visual disturbances. For example, if you look at halo effect, only 7% of patients reported to have seen halos, and this is very low, especially taking into consideration that A, we have confronted the patients directly with the pictures, B, we applied minimal vision in all patients, and C, this is about 1 month. So if you look in the literature, for example, for trifocal lenses, you will see that up to 90% of patients within the first month after surgery will report halo effect. 90% will report halo effect. So I would say these are very robust data from a retrospective study. The question here is that it, or do we still need something more? And I think we still need something more. The real deal, ladies and gentlemen, the real deal is always a direct head-to-head comparison between equal contenders, something which companies are most of the time not very fond of. And we are about to start such a comparison. We will compare ISOPURE with another next generation Edov lens in a prospective way in 130 eyes. We are working very hard, and we are confident that we will be able to present you the first data in 1 year from now. Thank you.